The iScoop makes intubation and spontaneous breathing practical, turning a complex, rarely used technique into routine care. The safest way to secure the airway is now poised to become the new standard for all patients. Guidelines favor intubation with preserved spontaneous breathing. However, even when a difficult airway is anticipated, it is used in only 2.7% of cases, and complications increase 45-fold as compared to patients with normal airways. Under analgosedation with spontaneous breathing, we must follow the airway's natural curved course in a tight, mobile space often laden with secretions. Even in experienced hands, the glottis is only partly visible because epiglottis cannot be lifted sufficiently and obscures the view. To obtain the clear view needed to judge whether the glottis is open or closed, the epiglottis has to be uploaded, and progress comes in tiny steps. Blade-based laryngoscopes require straightening an S-shaped airway to some extent to obtain glottis view. It demands force, soft tissue pressure, and stimulus. If we try to limit stimulus, we add complex maneuvers such as uploading the epiglottis with a blade. Nudge, withdraw, change the angle, repeat. 20 microtoms later, almost 2 minutes pass before the tube is in place. Under analgosedation with spontaneous breathing, every extra maneuver can trigger reflexes and movement. The safety margin shrinks. As long as intubation is this complex, spontaneous breathing approaches remain limited in everyday practice. So the question is not whether teams can do better, they already perform at a high level. The question is when mechanics align with physiology, when seeing, guiding, and acting follow the natural curves of the upper airway instead of fighting them. The epiglottis again occludes the view, making vision-guided placement impossible. The tube advances blindly, without visual guidance or confirmation of tracheal entry, and what cannot be seen cannot be controlled. With the iScoop, the viewing axis and working line meet at the laryngeal inlet. Dual optics and the tube guiding bar sit subepiglottic and provide a stable close-up from two perspectives. Patented and approved. In clinical use and continuously refined since regulatory approval in 2021. The iScoop is inserted anatomy-guided without a blade, like a laryngeal mask. A finely controllable epiglottis lifter gently opens laryngeal inlet with minimal force and very low stimulus. Both dual optics and the tube guiding bar are now directly in front of the laryngeal inlet, enabling stylet-free, vision-guided intubation. But what if gastric contents regurgitate during intubation? The iScoop closes the safety gap by integrating airway control and airway decontamination in one device. With the iScoop, the optional dual suction system rests at the lowest point of the upper airway, directly in front of the esophageal inlet, where secretions, blood, and gastric contents first accumulate. This delivers practical protection where it matters most: emergencies and high-risk patients. On the left, you see targeted topical tracheal anesthesia and a direct vision. On the right, about 1 minute later, a vision-guided tube placement. This also suits all elective patients with normal airways in day-to-day care because it's simple to use and broadly practical. All patients benefit immediately. No neuromuscular blockade, much lower anesthetic dose, fewer adverse events with steady hemodynamics, faster recovery, and few common morbidities such as sore throat dysphagia, vocal fold irritation. These key benefits for all patients support default use, building routine, and strengthening competence for difficult airways and the critical ill. The iScoop moves a rare exception to standard practice. It makes intuitive, vision-guided intubation with preserved spontaneous breathing practical as routine care across anesthesia, intensive care, and emergency medicine. By making the safer way the standard, the iScoop turns risk into reliability and makes routine care safe by default.